Yeah, so Peter and Benoit are
Good afternoon, everybody, and thank you for joining today's webinar on improving treatment for elderly patients with depression. Just as a reminder to everybody, we will be unmuting you at our end and leaving you unmuted as much as we can, but we ask you to keep your own line muted at your end in order to mitigate background noise, because you know, the sound of one person typing is not so bad. The sound of 20 people typing, as you can imagine, is quite deafening. So please keep your lines muted until you have a question or need to speak. At that point, you can unmute yourself and jump in. I believe Dr. Mulsant and Dr. Selby will be calling on the audience for questions at various points. So you'll be able to ask your questions out loud. If you prefer to send your questions in writing, there is a question panel on your screen there, and you can type in questions there, and I will be moderating those. So as soon as there's an appropriate place to ask your question, I will jump in and do that. And the other thing is there's a raise hand function on your screen. So when you, if you want to interrupt or jump in with a question, you know, say the topic is starting to move on and you think you need to jump in and ask a question from something previous, but you're not getting an opportunity to do so, you can raise your hand as well, and we will see that your hand is up and do our best to call on you. Without any further ado, I'm going to turn over the broadcast to our guests. Dr. Benoit Mulsant is from the Center for Addiction and Mental Health, as is his colleague, Dr. Peter Selby. And I will be, I'm turning over the presentation reins to them right now, and they will be making this presentation. So thank you very much, Dr. Benoit, Dr. Mulsant, and Kyle from CAMH for being here with us today and talking to our members about this initiative.
Yes. Hi, can you hear us?
I can hear you.
Okay, wonderful. So I'm Dr. Selby, and I have with me Dr. Benoit Mulsant, who is the chair of the Department of Psychiatry at the University of Toronto, and a world-renowned expert in geriatric psychiatry, especially geriatric late-life depression. And many of you know me through the STOPS program and STOPS study, and we had a wonderful conversation with the quid specialist this morning about this study. And so how we're going to divide up our time is we're going to open up with a presentation on late-life depression. That'll be done by Dr. Benoit Mulsant. And you know, how the cause and how it happens and the prevalence and what are some of the features of it and how it's treated. And then we will go into where the gap is and the reason for the study that we are talking about, so that we can talk about how we're going to we are attempting to fill that gap. So yeah, and you're just going to click. Sorry, I'm just going to show Dr. Mulsant. You have to show my screen. Okay, so can people see Dr. Mulsant's screen? It says
it just popped up for us now.
Did it pop up, Kath?
It has, yeah, it just came up.
Oh, fantastic. So, okay, so we'll get going, and I will just help Dr. Mulsant. Just 1 second, just hide this.
So good morning. My only issue is how to hide our icon. We can the control panel, and we can move it in the corner. Okay. Can everybody hear me? So thank you for the kind introduction. And thank you all of you to agree to participate. I've been told that I have about 15 to 20 minutes to talk about the treatment of the late-life depression. I'm going to focus on pharmacotherapy. During the question session, I'll be happy to answer and talk about the psychosocial intervention, the various psychotherapy if you're interested, but we are going to focus on pharmacotherapy. And so let me start with the slide. Now I cannot. I cannot.
Yeah, I show you.
Okay.
There you go.
So here is my disclosure. I receive no payment from any drug company, and I'm not promoting any specific drug. And most of the drug I'm going to talk about are actually generic medication, and that's the one I'm going to recommend to use. I've received some grants from various institutions like Brain Canada, CHR, the National Institute of Health, and drug company have provided some free drugs for those trials that were paid by federal dollars. So those are my, but I have no honorarium and I do no consulting. As I said, for the mitigation of the bias, I'm going to talk about various antidepressant, antipsychotic, but most of them are generic. And I also want to specify that some of the, I may mention, I don't think so when I think about it, but I may mention some off-label use. But otherwise, pretty much almost everything I'm going to talk about is covered by Health Canada indication. And if it's not, I will specify. We are talking of this gentleman, an older, and when we say older, when we say late life as opposed to geriatric, we are talking about 60. Because of ODB, there are some difference for the 60 to 64 versus the 65 who get in Ontario their drug for free. But we are not necessarily talking about the very old. Most of the data that we have in the study cover people from 60 to 80. There are very, very few. There are a couple of studies. We can talk about them during the question that are the very old, the people in their 80s, 90s, the long-term care patient. But most of it, we're talking about patients in their 60s and 70s. And the outline of my presentation, I will have one slide on prevalence and treatability, talk about what's happening in practice, and I'm not going to slam and say, oh, psychiatrists are wonderful and family physicians don't know what they are doing. I'm going to show you that psychiatrists don't do very well and family physicians don't.
Attendee quick start video. In this overview,
and so how people are doing. We'll talk about this then. I'm going to argue that we can do, all of us, psychiatrists, family doctor, working together, we could do better if we use a systematic approach. And some people call them protocol, algorithm, pathway, stepped care. But I'm going to make an argument for this approach based on data and clinical trial. And I will finish going back to when people hear about this, they say, well, what is the role of clinical skill? And then having one slide on treatment-resistant depression to introduce the presentation of Dr. Selby. So again, this is what I call therapeutic nihilism. You have the same older person on a chair looking at a brick wall. The children are worried, and the physicians say, and it's supposed to be a joke published in the New Yorker, a little bit the fact that people believe it's normal to be depressed when you are old and there is not much to do. And so my entire career has been about fighting therapeutic nihilism. And actually one thing that brought me to become a psychiatrist is I was very impressed in my younger days, 30 some years ago, how incredible impact could be the treatment of late life depression. If you have an old person who is not functioning, is very sick, a lot of need, very dependent, and they suffer from depression, and you treat the depression successfully, it can be a miracle. And I'm not going to talk about ECT and electroconvulsive therapy and inpatient, but that's really, you can do over 4-6 weeks, you can have a dramatic difference in a person's level of function and quality of life. You can also save their life. In Canada, the group with the highest suicide rate are still older men. So you all know that depression is prevalent, 3 to 5% in the community. It's actually the prevalence is lower than in midlife and in younger person, but it's still 3 and 5%. But in clinical setting, for instance, in a family practice office, the statistics, the epidemiologic data show it's 10 to 15%. Those patients who are older and depressed suffer, they somatize, they break their hip, they suffer heart attacks. So you see them in clinical setting at a high prevalence. The depression interfere with rehab, it interfere with care. It leads to non-adherence to diabetes medication and hypertension medication. So those patients get a lot of medical attention, and sometimes, you know, one problem with us physicians is we have a hierarchy of need, and we want first to fix the hypertension or the diabetes, and we know the depression is in the background, but we say we'll take care of it when the diabetes is under control, without necessarily realizing that the patient is not taking his anti-diabetic medication, and you actually need to treat the depression first. So there is also the issue of growing a population with an increase of prevalence just because the population is aging. And then, as I say, I'm not going to show you all the slides, but one study that I did with colleagues in a clinic where we use an algorithm, a five-step, in a mixture of psychotherapy, medication, and at the end of the year, of the 173 patients who had initiated treatment, 87% responded. There was only 4 who failed the 5-step and 9% dropped out. So we helped the majority of patients, and most of patients who were not able to help is because they gave up. So I'm a guy who said to patients, if you don't give up, we won't give up, and I'm absolutely sure we'll be able to treat your depression. I'm not a believer in treatment refractory depression, but you need to give us a chance to help you. And I also tell them the difficulties, I don't know if you will be better in 2 months or in 2 years, and the goal of us working together is to try to do it faster, but it is still a trial and error process, unfortunately. We cannot yet predict in advance who will respond or who won't respond. So the barrier to the treatment, I've already touched on them. There is a low initiation of treatment. There's still some stigma, in particular in that generation. Some families, some patients don't want to be treated. Some physicians want to treat patients, but feel they need to focus on what they view as more urgent medical problem, without necessarily realizing that by treating the depression first, they can really decrease the morbidity and improve adherence and treatment of other problems. There is poor adherence. The patient we start on medication, a lot of them, older patients, don't fill the prescription or fill but don't take it, or take it partially. Then you have the people who get better early in the treatment, but then they say, I'm better, and they stop their antidepressant and they relapse. So when the researcher come knocking on the door 3 or 4 months later, they're in the non-remission because they lost the benefit of early treatment, because they didn't understand that you need to treat depression more like hypertension. It's a chronic illness model. Once you get well, you need to continue the antidepressant, not to get better, but to stay well. Then there are people who have partial remission, and then sometimes the patient and the doctor say that's good enough, and those people actually continue to suffer, and we know that those partial remission patients at high risk for recurrence and chronicity. So the goal when you treat late-life depression is full remission, absence of symptoms. We know that when we don't do all this, I'm not going to show all the slides, but I've mentioned increased disability, fall, fracture, not rehabilitation. We also know that, as I said, those patients suffer, so they somatize, they complain of chronic pain, weakness, poor sleep. They end up being treated with inappropriate medication, opioid, benzodiazepine, which by themselves cause additional morbidity and mortality. And we have some data that I won't show you, that the successful treatment of depression in older people decrease mortality, not just from suicide, but also from general medical condition. And then I've mentioned a group at high risk for suicide, which is in the top 10 cause of death in Canada. So a quote from Tom Insel, who was the NIMH director up to a couple of years ago, and in his last blog when he left, he talked about that challenge, improving the quality of mental health care. And he said, with what we have now, we could do much better, but there is a gap between what we know and what we do. And here is my slide, what I call a tale of two approach, about what we know and what we do. So I'm going to show you a few studies to show you we know that the systematic approach based on evidence and help physicians to develop more, treat a large number of patients with the same treatment. You increase your confidence in those treatments. You convey it to your patient. Your patients are more likely to take the medication, and they are more likely to get better. And it also helps all of us to keep the course, as opposed to the usual care for many psychiatrists, many family physicians, where we see those people who suffer. We feel uncertain. We keep changing medication. We keep changing dosage. And we treat people with too many medications. We have too many antidepressants. Not that we don't have enough. We have too many good antidepressants in Canada. And then and then the patients feel that the doctor is not certain. They don't take the drug. Then they come, they suffer, we switch them. And in the end, we spend a lot of time obsessing about which drug to use instead of remembering the main lesson for me of my professional life and the research and the clinical practices. It's the way you do it. It's a process of care more than the specific medication that you use. All the antidepressants that are approved by Health Canada work better than placebo and will give you about 40% to 50% of remission if you use them well. And so if you go to 2 or 3 in a row, you should have the 80, 75% that we talk about. But unfortunately, here is a slide about psychiatrists treating depression in adults. I don't have it in geriatric, but it's the same issue. So in this study, to show my point, the researchers say you can use only 2 antidepressants. So they fix the drug, and to show that the skill are not in picking the best drug or a miraculous drug or a new drug. They pick paroxetine and mirtazapine, and those psychiatrists were told, use those 2 drugs, you have 6 months and do the best you can. And that you can see in the orange line, they had about 24% of patients getting remission over the first 12 weeks, and then absolutely no change during the following 12 weeks. When they were using the same medication, but with an algorithm, which what they call those researchers measurement-based care, they were able to get 78% of their patient remission, and all of them in 12 weeks. And the algorithm was not complicated, was a simple self-assessment, which they use a quiz, but something like the PHQ-9 you may be more familiar, and saying to the patient who were depressed, if the patient remained depressed, we increase the dosage. If they remain depressed when they have at the maximum tolerated dosage, we switch to the second drug. If you have side effects, we decrease the dosage. If you have too many side effects, we switch the drug. So to make it 25% versus 80%. It's the way you use the drug. It's not the drug itself. Same study done in primary care by my colleague. I'm a co-author on those papers, showing people randomized to usual care in U.S. family practices or randomized to an algorithm treatment with a healthcare technician who does the measurements and does the psychoeducation for the patient. And you can see in the pink line that the patients who are treated in the algorithm with a family physician working collaboratively with a psychiatrist and a technician, more rapid remission and more remission over 18 months. And the secret is here. When you look at what happened over 2 years of treatment in that study, the patients who were treated according to the algorithm with the help of a technician, 90% of them were able to receive adequate treatment and go through various steps over 2 years. The primary care physician on his own was able to get about 50% of patients treated adequately. So, and that's not a criticism of family physician. They know the drug, they know what to do. It's the family practice are not organized to offer optimal care for depression. And the reason is, and that's my last versus before last slide, is the need of clinical skills. The patient must be seen regularly. All the guidelines say if you want to treat depression acutely, you need to see over the next 2 months your patient between 5 and 6 times. And most physicians, psychiatrists, and family physicians don't have that amount of time available for one patient. They also say you need to do psychoeducation, encouragement, and support. And the typical visit should be 20 to 30 minutes. And again, people don't have necessarily that time. There is a whole interesting issue of how to address the person's illness model, how they understand their depression, and how they understand the treatment you propose will help them. An example in late life, a woman who has lost her husband, and you give them, she's depressed, she's not sleeping, she's not eating, she's losing weight, she's starting to thinking of dying to join her husband. If you give her an antidepressant or I give her an antidepressant, she may feel insulted. So you need to do some explanation of why you are treating the death of her husband with a pill will not give her husband. The patient who has back pain or cannot sleep and you want to give them antidepressant, you need to have the time to explain to them why you're not giving them a painkiller or sleeping pill. And that takes time, and most of us in a typical practice don't have the time. It also needs to educate the patient that they may get worse for the first couple of weeks, where they get all the side effects and not yet any benefit. And many patients, as I've mentioned, stop early. And then telling them the side effect will happen, but it's not a bad sign. That means the medication is working on your body, and your body will get used to them in a couple of weeks, and then the therapeutic effect will start kicking in. And then finally, I've already mentioned the importance of explaining to the patient that when they get well, they need to keep the antidepressant. And various guidelines recommend a minimum of 6 to 12 months, maybe longer for older patients. One slide about treatment resistance to show you meta-analysis. Look in the middle, the best treatment was sequential treatment program. It was not, again, venlafaxine or duloxetine or antidepressant plus this. It was going through some steps and helping the patient. And as you can see, they got 87% of their patient well with that sequential step. In conclusion, I hope I've convinced you that late life depression is worth treating, can be treated, but that it requires systematic approach and persistence. Do not give up on your patient. They won't give up on you. And now Dr. Selby will talk with you about a program that we are launching that may be a benefit for those of you who want to create a partnership to kind of implement that systematic approach. I thank you for your attention. I'm not going to take any question. I will answer the question with Dr. Selby when I'm finished. So I don't know how. I suspect we need to move the slide. Escape. No, you know what? We're going to try to just close my slide. Close my slide, not the. So
yeah, there.
Where?
Top one at the bottom. Just switch it.
Switch.
Okay.
Okay, and then
Okay.
here, and Peter, it's yours. Why don't you move in front of the mic?
Thank you. So thank you, Dr. Mulsant, for that very comprehensive overview in less than 20 minutes. That was amazing. So you covered a lot. So keep that issue in mind. That what Dr. Mulsant talked about is that if we do something, systematically, and we do it well, we actually get outcomes. I mean, and that's essentially the sort of definition of excellence, is doing, common, mundane, routine things extraordinarily well. So part of it is that there's a lot we know about management of depression, and even depression in the elderly, but for all the reasons that are going on outside at the clinic level, at the knowledge level, at the practice level, at the patient level, those things can sort of erode. So what we want to talk about is a trial, a study, which is what we would call pragmatic. And what pragmatic means is that these studies are looking at how do interventions work, for whom do they work, under what conditions, and how well do they work under those conditions. So it's not so much as to whether it works or not. That Dr. Mulsant has shown you does work. The question is, does this work in the real world, and are the outcomes that we are studying here relevant to the patient as well as to the practitioners who are doing this? So what we are trying to do in this study is to really look at, again, this similar patient population we just talked about, and I'm just going to try to make sure slides advance, is to take a look at this and understand it much more closely. So let us give us a shout out to the funders, which come from south of the border, and the short form is PCORI, P-C-O-R-I, which is Patient-Centered Outcomes Research Institute. And they're the ones who funded it. It was created by the Affordable Care Act in the U.S., and it's funded by U.S. Treasury, Medicare, and Medicaid, and a fee on a commercial insurance. But what we look at these kinds of studies is that we're going to compare three sort of different treatment type interventions and see which one works best for whom in a real-world setting. And then the other part of it is that we also make sure that there's an intentionality of engagement of patients, physicians, and families in every stage of the research process. And of course, you can't do, the entire engagement process before the study is started, but for obvious reasons. But once you've got sort of the study out, then you start making sure you engage people. And so part of this talk today is to really engage frontline caregivers and frontline providers in this study. So treatment-resistant depression, which has been operationalized for this study in the following way, that people have been on treatment with 2 or more standard antidepressants. And you can see in that example is that the person may have taken sertraline for 3 months and then did not respond and then got switched to venlafaxine again for another 3 months, and again, no response. So roughly 12 weeks, and you can tell that they've been taking it. Then, if they still have depressive symptoms, this is whom the study is for. And clearly, the idea is because we don't know which is the best option, we need to study in the real world which treatment pathway would be the best pathway for patients who are suffering from treatment-resistant depression. So you've heard about, and I'm not going to spend too much time on this other than to say that if we don't treat depression in the elderly, we get a lot of secondary complications, and we're not getting down to the root cause of why somebody may be withdrawing and not getting out and falling and not interested in taking their medications for other conditions and not getting their blood pressure under control, et cetera, et cetera. So, so this is the idea, is to make sure that this treatment that we're giving will actually have these patient relevant outcomes at the end of it. So part of the Optimum study is that we are one of 5 sites in the world. 4 of them are in the U.S. One is in Canada, situated at U of T, at CAMH, and at the University of Toronto. But it means that people who want to participate in this can come from anywhere in Ontario. They don't have, the beauty of this is that they don't have to travel to CAMH in the city or come into the city of Toronto. This is, the treatment can be, or the study can be operationalized anywhere the patient might be or the team might be. So the important part of this is the patients stay with their own provider. The provider is the one who prescribes the medication, not us. It's based on a recommendation and the steps that we give to the provider, but it's really, at the end of the day, the relationship between the provider and the patient is maintained. There is no interference in any way by the study team in that relationship. So let me walk you through how the study design is. Overall, across all the 5 sites, we want to get 1,500 patients. And as we talked about it, the age has to be 60 plus, suffer from major depression, and has not responded to 2 or more antidepressant trials. Of course, there are other criteria, like they shouldn't be suffering from dementia, they shouldn't be suffering from Parkinson's, but we will do that screening to make sure that they don't that they meet criteria. Once we interview them and they're deemed eligible, they can be, by random allocation, the recommendation to their provider would be, you could keep the current medication this patient is on, but just add aripiprazole, which is another kind of antidepressant, neuroleptic kind of medication that could help. The second one is add bupropion. And the third one is stop the medication the patient's on and switch to bupropion. So you can see that nobody in this gets placebo. There is no placebo group. Nobody is going to get no treatment. Everybody gets treatment. And the reason why there's an equal probability of getting each of these treatments is because we don't know which treatment is better. So as a result, once the study is done, you can compare who did better under what treatment condition. Now, they get this medication for 10 weeks, and the important thing here to remember is that the decision to start the treatment, to follow the recommendation, to stop the recommendation is, at the end of the day, a joint decision between the provider and the patient. So at any time they can make a decision, and it could be based because the doctor and the patient feel they can't tolerate the medication or they're not responding to it. It could be based on that. Interestingly, what we do in the meanwhile, as the study is going on, is that the study team from Toronto will be calling the patient every 2 weeks to check in with them to see how they're doing, their side effects, are they taking the medications, and what else is happening, what else is happening to their depressive symptoms, their well-being, their safety, if they have any falls, their cognitive function, and their mobility. And all of this is then shared regularly with the practice. So the practice gets an update on a regular basis without needing any more resources to be utilized in the practice. So this remote team takes care of all of that and keeps updating the physician and the practice as to what's going on. Really the goal is to look at whether the symptoms remit and whether people are getting better and feeling better about it. And we also take a look, as I said, to cognitive function and mobility. So these are all the sort of pragmatic outcome measures, as opposed to just saying, well, the person had fewer depression scores, they improved their depression scores. This is really about functioning and looking at how they're doing. And then once they finish that 10 weeks, they go into the continuation phase to see how they persist, how they're doing, do they maintain the gains, what else, what other treatments they took, and these are, we touch base with them at 4, 8, and 12 months. So that's the study design. In Ontario, we're hoping to get 300 patients and roughly about 150 patients a year. So who is eligible for Optimum? So clearly, as we said, it's both men and women of any ethnicity, any background, as long as they can speak English, age 60 or older, and they should have treatment-resistant depression defined by major depression, a PHQ-9 of 6 or greater, and 2 or more failed trials of antidepressant medications. And as I said, the only exclusion would be obviously if they have dementia, because clearly it's hard to get consent from somebody who has dementia, unstable medical illness, and unable to take any of the Optimum medications. So if they have very significant heart disease or things that the treating physician suggests that, this would be too risky for this patient, the patient isn't eligible. One of the beauties of this is that if practices are not sure, excuse me, they can refer them to us, and we can do that assessment by phone and offer an informal consultation back to the practice and say, hey, this patient, it doesn't sound like they have treatment-resistant depression. It's just maybe that depression hasn't been treated properly. And here are some recommendations. You could increase the dose. You could switch. Here are some sort of informal consult about what your patient could benefit from. And if they don't respond to those antidepressants, then they can come back into the Optimum study or another treatment. So what we are saying to people is that you're better off referring more liberally initially. As the study goes on, you'll get sort of more comfortable knowing exactly what the criteria are. So here's a column of the PHQ-9, which shows you the questions and that tells you how we look at it. And as these are scored, and if any of you are in the STOP study and are using the PHQ-9 is already being used in everybody who's enrolled in the STOP program. So these questions should be quite familiar to you if you're an implementer in the STOP program, but really it asks about symptoms in the last 2 weeks and talks about whether people are having a little interest in doing things, feeling down or depressed or hopeless, and again, asking, about suicidality. So really, if the score persists below 6, goes up, persists above 6, then there may be some recommendations for a medication or a dose adjustment. So here's how it works. If any practitioner wants to participate, and we have a slightly different model for sort of AFTO members. But if an individual practitioner says, I have patients, they can just refer them to the study, and we'll screen them and let them know if they're eligible. The prescriber signs an agreement as well as a one-time agreement, and then every patient gets of that patient gets consented. What they will do is they will be screened by us. If they're eligible, then you'll get a report after that first assessment to tell you that your patient has been assessed. Here's the recommended treatment, and please prescribe it. And so that is expected of the physician. As we said, the patient is called every 2 weeks and monitored that way. And clearly, the recommendations are about dose adjustments, whether it's going up, or stopping, or going down. And again, this is kind of a collaborative care model whereby we're not going to be disrupting the flow of the clinic. So we don't have to sit in the clinic and wait for the patient to come or need a space. This is all done remotely. And if the patient has a side effect or other problem, we'll be checking on it proactively. But of course, sometimes they may call your office. You report it to us. We follow up with them. And the study psychiatrist will provide clinical recommendations to you and the patient based on the safety of the labs and of drug monitoring that's going on. In terms of ensuring there's compensation for the practitioner in the sense that, for the participants will be compensated at $60 for the initial screening visit and $30 for each assessment visit after that. And clinicians will also receive some compensation for their time. So, as I said, providers who are interested go through an informed consent process, and if they agree to participate, as I said, they sign an informed form and become participants on the study, and then we begin working with your patients. So what are the potential benefits to your practice? That obviously, as we talked about, you're better able to continue to provide and improve on the provision of treatment of depression in the elderly, and really learn the state-of-the-art science in these prescribing practices about medications, what is required, and have sort of like a pit crew who's looking out for your patient while not slowing you down while you do your other work. The other thing is you'll receive regular decision support from our geriatric psychiatrist that is specific to each patient. So some of you may be participating in e-consults, but that's a one-off. This is ongoing and allows that sort of ongoing monitoring while the patient is being helped to achieve remission of their depressive symptoms. You get a treatment recommendation more specifically, as we mentioned, but you also get referral, sort of informal consults about your patients who've come in with, who are over 60 and might have depressive symptoms, but you're going to get some recommendations if they don't meet criteria. So really, from that perspective, you're improving the quality of care, not just of the patients who participate in the study, but also getting advice and guidance of those who don't. And again, there is a true partnership. We don't expect practices to do this for free. There is a compensation, as we mentioned, for the practice for any of the kind of patient-finding activities needed. So whether it's looking at the EMR or it's making those referrals, etc., there is compensation to the practice. I'm not going to go into the details here because I think we have a mixed audience here. So what I'm going to talk about is that for each medication, there's a starting dose, there's a target dose that we need to get to, and a maximum dose. And how those doses are increased are sort of in this guide. And again, the study team will recommend these increases every 2 weeks after the initial call and the ongoing calls with the client. And so those recommendations will be made based on the symptoms and tolerability. We'll look at these are the side effects that medication can cause, and these are the safety labs and monitoring that are required for people who are given these medications. So this medication particularly. If people are being given bupropion, here's the recommendation of the starting dose, the target dose, and the maximum dose based on a case-by-case basis. And again, when the titration will happen, what the side effects are, and what safety and monitoring would look like. this slide is much more for the U.S. Federal regulation, and yes, we will regulate, so I'm just going to skip this. But we do know the study has been approved by the REB at ChemH, and clearly will cover participants in the study, both the practitioner and we have an agreement with the practitioner, and will cover the patient. So this study essentially now is, to summarize, is really adding to usual clinical care, because people are going to get access to new treatment options. Now, all these medications are available in Ontario, so we're not giving medication options that are just, some experimental drug. These are known medications, and they're Health Canada approved and can be used in this, and are on ODB as well for those who need it on ODB. The goal is, as practitioners also participate in this, and with the consults, there will be learning going on, and essentially can apply some of the results to the care of the other patients in sort of treating late life depression overall. We are also having a study advisory board that includes membership from AFTO and from Nurse Practitioner Association of Ontario and other groups, and the Ontario College of Family Physicians and other groups, and a patient as well, so that we can make sure that as we are going on, this study is going on, first of all, ethically, because it's under the REB, but also to understand and help us understand what are the realities of the different sectors as they try to address some of these really significant problems of mental illness in primary care settings and real-world settings. So that was a quick run through. We are hoping to have at least about 75 patients in this year, if we can. And if you look at the slide, we have the study website for more details, how to refer a patient on the left-hand side, and the people who you can connect about the study, patient, and treatments. And of course, for some reason, my name sort of disappeared off this slide, but you can also connect with me about it. So for that reason, I think we're going to stop the slides now and open it up for questions and comments, and we'll open up that. So we have time. We have 20 minutes for questions for both Dr. Mulsant and myself. So feel free to type it in.
And we don't need to have questions only about the study or I'm happy to talk about, as I said, if you have questions about psychotherapy, ECT, other medication, if you disagree with some of the things I said or it doesn't jive with your clinical experience, Dr. Selby can talk from the perspective of a family physician with a lot of experience in mental health. I can talk from the expertise of somebody who does still consult for family physician pretty much every week. We see 1 or 2 consults of older patients with depression, and realizing what people are struggling with.
Thank you, Drs. Selby and Mulsant. And so just a reminder to folks on the line, we were getting some background noise during the presentation. So anybody who had not muted themselves, we've gone ahead and muted you. So if you do need to speak and you find that you're muted from our end, please raise your hand and we will unmute you. If you've muted yourself, you can go ahead and unmute yourself.
Maybe people are shy and don't want to go forward, but I mean, we are interested in getting your perspective. Obviously, you decided to attend this webinar. Do you find it hard or easy to treat your older patient who present with depression? Sometimes people tell us we don't see older patients with depression in our practice. So is that maybe asking you what motivated people to attend the webinar. Is there any problem, or we want to run a case?
Oh, and I see somebody's got a hand up. Charlene, you are unmuted. You can go ahead sorry, Charlene Welsh. We have two Charlene's on the line. You're unmuted. You can go ahead and ask your question.
Okay, I'm just calling from the Pickering area at the Western Family Health Team. I was in and out during the presentation. I'm just wondering if the slides are going to be available as a reference point to help us make decisions in patient referrals.
Happy to share the slide with AFTO, and we can certainly send them, and then if AFTO want to make them available or put them on the website, we are happy to make them available.
That would be great. Thank you.
And we will happily put those up on our website. So they'll be linked to from the event page where you got to this from. We will have the slides and make sure that we have all of the email addresses for the presenters as well up there.
The other thing, if I can just add, with AFTO specifically, because AFTO has run some depression queries in the EMR, if there are practices interested in running those queries, please connect with AFTO, and those queries can be run in your EMR. And what it'll do is it'll pick up people who've been on over the age of 60 who've been on 2 or more antidepressants, generate a list, and so proactively, rather than having to remember in the moment, you could proactively identify your patients who might have late life depression. You could either call them yourselves, or we could call them and assess them, and say that we got a referral, we're just following up, and then make an assessment and a judgment based on our call with them as to whether they would be eligible or whether you would need a recommendation about how to optimize their current treatment. So that's the unique sort of relationship that we are going to have with AFTO, is the use of the queries, depression queries, to improve the quality of care provided to people with depression, using it to identify patients with late life depression who might be treatment resistant.
Absolutely, and if I can just take over the screen for a moment, and I will give it right back to you. I'm trying to get the right.
And it says, do I have to give it back to you, or can you take it back?
No, I should be able to take it back. Sorry, it's just.
Okay.
So what you can see on your screen here, this is on our website under effective use of EMRs, getting started with a registry for patients with depression. And if you scroll down, this has links to the depression queries. So you can see here, if you're on PSS, we have a file that you can import into your EMR, and you can email. You can email us. There's a name here, but you can email us, and we'll direct it to the right person to get the file. For people who are using Akiro, there is the query is available from your Akiro publisher, and we're in the process of creating depression queries for Oscar. Right. And I don't know where we're at on that process. Greg, if you are listening in, perhaps you can chime in with some updates on that. So this page actually is an even better one. So you can see the URL, though. I'm going to post it into the chat box for everybody. And that's our web page with all of our standard queries and where to go for ones that we don't have that you can get from elsewhere. And these were developed with cooperation of CAMH. So thank you very much for developing those. And this is a great start for helping to identify those patients who might benefit from this trial. And now I'm going to give the presentation back to Dr. Mulsant.
Okay, it's Greg Mitchell here. I want to clarify, we do have queries for both TELUS PS, Acuro, and Oscar. So queries are available for all three.
Thank you. So I guess our website needs to be updated about that. Thank you, Greg. And I am posting that URL here into the chat pane for everybody. Shilpa, my colleague Shilpa has a question. Go ahead, Dr. Shilpa.
So I got a question from someone asking if, remind me if the patient can have a comorbid psychiatric condition such as schizophrenia or bipolar?
No. So this is, for this study, it'll be, only a major depressive disorder and no other major psychiatric disorder. So no bipolar, no severe mental illness like schizophrenia. But the anxiety disorder is okay if they're using alcohol, but as long as they don't meet active alcohol dependence, they could be fine. If they're using marijuana, that becomes.
By the way, one clarification. If you have a patient and you're not sure about the eligibility because you don't want to go through all those differences, they can be referred. And if they agree to participate, it will start with a kind of diagnostic interview that can be done by phone. If they are found to be ineligible because they meet criteria, for instance, for bipolar, then we'll let you know and we'll let the patient know and we'll recommend a referral to the mental health system. We have done another study called Partners that was in adult, and that was one of the benefits of the study. In about 25% of the patient referred for the study, we found a problem that was probably not detected by the family practice. An example, we found some people who were referred for depression actually met criteria for bipolar, and whom it would be unsafe to start an antidepressant without a mood stabilizer. We found some people where people thought they just had a drinking problem, but in addition, we found they were abusing cocaine or they were other street drug. So we found some people with severe PTSD or OCD that could not be treated in the study. So part of the benefit was and even in those with depression, in about a third, we detected some problematic alcohol use that we were able to manage in the study that was not necessarily detected in the practice. So the referral of those patients were very quick. Just Mrs. Smith seems to suffer from depression, and I'm wondering if you would be interested in participating in the study. I've already tried a couple of antidepressants who have not made a lot of progress. Would you be interested to participate in a project that we're doing with the University of Toronto or CAMH, and where you may get additional service and support if you're eligible? Patients say yes. You just fill the fax, Mrs. Smith, here is her phone number. She wants to be called in the evening or in the middle of the day. Then we call her. We will do that diagnostic assessment. We hope that most of them will meet criteria and then can receive the support. But even if they don't, it's not a waste of time. You will get a free clarification based on a validated diagnostic interview, and we'll say, your patient does have depressive symptoms, but also report X, Y, and Z that make them ineligible. And if you are in the GTA, by the way, and you don't want to treat the patient yourself because you don't have the time or the interest, we welcome the idea. They can be referred and we'll see them in person, but then they have to come to a CAMH site. We will, within the next we are going through an approval of what's called Clinical Trial Ontario, and we'll actually have a site at Sunnybrook and one at Beckrest. So if you are in the GTA and you want to refer your patient and they are willing to travel, they can come to one of our sites. But if you are in Sudbury or in Sault Ste. Marie, the only practical thing is to do it by a phone. And for people, by the way, who are, let's say in Barrie, if your patient, you don't want to do the trial and prescribe the medication yourself, but you want to refer them, and they are willing to drive to Sunnybrook or to Beckrest, they could be seen there once, and the rest of the trial can be done by phone with 1 or 2 visits. So remember, even for those, they don't need to see you. The whole idea of the support is provided by phone, because that's one of the problems, is you don't have the time. Most psychiatrists don't have the time to see people often enough. You offering them 5 or 6 visits over 10 weeks is taxing for everybody. So that's why it's doable by phone. I don't know if people are shy or if people need to go back to see their patient. It's almost 1. I think Dr. Selby and I want to thank you very much for your attention. As Dr. Selby mentioned, if you have any question, please send us an email. The Athena Pervolorist to coordinate is probably the person that is the best suited to, if you want to have a follow-up phone call, you want to discuss specific issues specific to your practice, she can organize that. Dr. Selby or I will be delighted to attend. If you want to ask something that's not related to the study but related to depression in older people, you have my email, and I may not be able to respond in 1 day or 2, but I'm happy if there's something I said on the slide that bother you or you want more other reference, please do not hesitate to email us or call us. And again, thank you very much for AFTO to give us the opportunity to talk to you, and I hope what we presented may be of help to some of you.
Thank you so much, Drs. Mulsant and Selby. Really appreciated you taking the time to talk to our members about this, and we will be following up with the information on our website. And with your permission, we would also like to post a recording of this webinar for anybody who would like to review it or share it with a colleague.
Of course.
Absolutely.
Thank you very much. Have a wonderful day, and thank you to everybody who joined us today.
Well, thank you for having us.
Thank you.
Thanks.
Bye-bye.
Bye.
Bye-bye.
You.